Hi, and thank you very much for joining us today. It's been a long day at the SCTS here in Birmingham, and I'm Mohammed Bashir for the CTSNet Aortic Portal. And again, today we're going to be discussing a very hot, controversial, debatable topic. It's about chronic type B dissection. Should we operate open repair, or should we just leave it as an endovascular TEVAR? For this, I've rounded a very eminent panel, which I don't need to introduce them, but just for the sake of this interview, on my left here, I've got Professor Malik Schwester from Hanover, Germany. I've got also Dr. Mark Chapin from Belgium. I've got also Professor Thierry Carrel from the University Hospital of Bern in Switzerland. Professor Joe Bavaria from the University of Pennsylvania in the US. And I've got Professor Christoph Nienaber from the Royal Brompton Harefield Hospital in London. And I've got also Professor Ong U from Liverpool Heart and Chest Hospital. Thank you very much for joining us all today. I promise that this discussion, I'm going to limit it to 20 minutes, so I don't take long from your time. I'm sure they're all busy with other commitments today. Right, so let's cut to the chase. The management of chronic type B dissection has recently been the center of interdisciplinary team, consensus, expert, and attention. Although the strategies in their documents or in the consensus, wherever they are published in the literature, were based on non-robust evidence for management of type B aortic dissection. They advise that the literature results are largely heterogeneous and should be interpreted very cautiously. My first question, and I would, would ask anybody to volunteer for this, is in this unclear atmosphere of chronic type B dissection, what is the management plan for acute, subacute, and chronic type B dissection? Professor Carrel, would you like to comment on this as a start off?
I think in acute type B dissection, the situation is easier because the morphology of the aorta is usually quite similar in contrast to the type B. So we are eager to treat every patient with what we call a complex type B dissection. These are clear, definite options like pains, hypertension, expanding aneurysm, or any kind of malperfusion. So I think these indications have been largely recognized. The other controversies, should we treat a patient with an uncomplicated dissection just to seal and to prevent further complication? And this is probably the question which is asked, how is the acute type B developing in the chronic phase? And this is less easier to answer, probably.
Dr. Bavaria, would you like to add any comment on this?
Well, yes. I believe that the acute, really it's acute complicated type B dissection. It's acute uncomplicated type B dissection with high risk features for late aortic developments, late aortic negative developments. And then there's acute uncomplicated without those issues. So acute uncomplicated without any other problems, without any other anatomic features for high risk late aortic events, that's the big question mark, whether we should be treating those medically or with a TEVAR. I think that acute complicated is obvious, you treat them with a TEVAR. Acute complicated with high risk features, and we have Christoph maybe could talk to us about what are high risk features. But those, I think there's a general consensus that should be treated with a TEVAR at this point by most experts. So those are the main areas. Chronic dissection is a totally different animal.
Excellent. I'm just going to stay, Professor Bavaria, on this comment about the complicated and non-complicated. Dr. Chapin, you were among the steering group for the recent consensus document that was published recently. One of the beautiful things that was written in the document is the definition of complication of chronic type B dissection. Would you like to elaborate further on this?
Well, if it is ruptured, there is no discussion. There is much more discussion when it's chronic pain or pain that is not treatable with painkillers. When there is rapid expansion, define it to me. What is rapid expansion? If you have 2 consecutive CT scans with an enlargement of 1 centimeter in a short time period, I think you have sufficient elements to say that you have to treat this patient on a short time basis. Another thing is malperfusion. I think also in this situation there is no discussion that the patient should be treated with an endoprosthesis. Yeah, that's about it.
Right, Smashin. I will just move the question now to Prof. Nienaber. The INSTEAD trial has offered a lot. We learned a lot from it. What would you say? What have we learned? Where does it stand now? How this has added to our knowledge of chronic type B dissection that Dr. Bavaria mentioned earlier?
Well, thanks for the question. The INSTEAD trial is now a little bit dated. It was a first-generation device trial, if you want, in patients that survived the initial impact of a dissection. So in the chronic phase, as chronic was determined or defined at the time, 2 weeks after the impact, the patient was selected for a randomized treatment of TEVAR plus medical management versus medical management alone. In the meantime, we know that the long-term follow-ups show a beneficial effect long-term in terms of lower rates of complications, lower rupture rates, and significantly better survival in the preemptively treated group. At the same time, in the registry, and we are going to talk about this later, the IRAD registry, we found exactly the same signal. Patient that survived the initial 2 weeks benefited from an early TEVAR as a preemptive measurement, as a preemptive treatment. And that now seems to be reported by various other series. The IRAD registry itself could show exactly the same thing like the trial. And moreover, now, 5-7 years later, we're dealing with a second, third generation of stent graft that make it much easier and safer to treat these patients. So our base of knowledge has been expanded while the data are basically aging.
Okay. I'm going to turn the question now to Malak. From your own experience, what are the predictors of adverse outcomes in each setting of, acute, subacute, or chronic? Or, you could just bundle them all together.
Well, at least in Hanover, we are still a little bit more conservative than what Professor Nienaber says. We still tend not to do anything if the patient doesn't have any complications and wait for the medical management. Only if the patient has any complication, then we go for treatment. And usually it's we have a combined meeting with the vascular surgeon, and only if the vascular surgeon says that he cannot stent it, then we go for the operation. And that means that depending on the anatomical features, whether the distal arch is involved or not, then you have to choose the right operation for that. If the distal arch or the mid arch is sometimes involved and there is no landing zone which the vascular surgeon can put in TEVAR, then you may have to open the chest from the front and put in a frozen elephant trunk. Or sometimes, rarely, it is fortunately very, very rarely that I've had to do 2 cases within the last 1 year where I had to do a classical descending replacement in an acute setting, which is sometimes horrible because of the bleeding. So that's, from the surgical point of view, that's the most, I would say, the difficult part for us.
Well, this is the most important question.
Yes, definitely.
So we have very clear evidence that you need, so clear that it's actually malpractice not to put a TEVAR in an acute complicated type B dissection. On the other hand, for uncomplicated dissections, for truly uncomplicated dissections, we do have a situation where we don't know the right answer. But in the middle, there's acute uncomplicated dissections that have high-risk features for late aortic and negative outcomes. And those need to be understood by this audience. Okay, it's very important that they're understood by this audience. Big primary tear sites, over 10 millimeters. And correct me if I'm wrong, because Christoph and I agree on this very, very important point. If you have a large false lumen in relationship to the true lumen, if you have an absolute diameter, adventitious diameter of more than 4 centimeters, and you can name off a few more.
Yeah, I would just latch on, and this high-risk group needs to be identified. And as long as you identify 1 or 2 of these high-risk features, the patient is a candidate to benefit from a preemptive procedure, meaning TEVAR, or a reconstruction of the true lumen. And in addition to the mentioned high-risk profiles like big entry tear, single entry tear, rapid expansion, large diameter of the false lumen, or even the newest parameter, the total diameter of the aorta expanding to more than 35 millimeters is already a bad sign. And in my practice, I don't see patients that have a smaller diameter than 35 millimeters with a dissection. So on retrospect, and if I believe the data that just were published from Boston, a total diameter of 35 millimeters is a high-risk feature and selects a patient for TEVAR.
I'm going to stay with the point on the data that you mentioned, Christoph, and I'm going to turn the question now to Prof. Wu. There are many published outcome data on TEVAR versus open surgery. We know that in Liverpool you advocate open surgery when it is necessitated and what is obviously required, knowing that most studies do not specify whether treatment was performed during the subacute phase. Therefore, analysis was performed on all available patient data with the understanding that pooling of subacute and true chronic dissection in complicated and uncomplicated patients might create some biases. Would you like to share with us what are the outcomes that you know of? Because it's quite confusing. I also read the consensus that Mark has worked on, and I'm sure he shares the same pointers with me. Prof. Wu.
That's right. The data out there is not clear for chronic dissection, and very little data to compare between TEVAR for the chronic dissection, truly chronic dissection, and then against open surgery. There are very limited kind of series of the kind of open surgery, and then limited number of TEVAR or the branch kind of thoracoabdominal or fenestrative for chronic dissection. And so when you look at the small number or comparison, and they come up with about 6.6 or 7% mortality for TEVAR group. And then when you have a kind of open surgery group, and then with a relatively small series, just coming up with about 8 or 9% mortality. But that's not what the reality is out there. And that's something that we need to have a kind of more experience to put together. One thing, let me go back to acute and subacute. That's more important. I think we need to have a kind of agree a standard of diagnosis, early assessment for all the malperfusion, and then the agreed principle for treating malperfusion. All the malperfusion, complicated type B, should be treated with TEVAR and require branch stenting into the kind of mesenteric vessels and renals aggressively, together with aggressive medical therapy. And then if it's uncomplicated type B dissection in the acute and the subacute setting, then we should routinely assess them in early post dissection, probably about 3-4 weeks down the kind of initial onset. And then we should have a criteria to look at patient with a high risk for complication, like large fenestration, large false lumen diameter greater than 22 millimeter, initial and then descending greater than kind of the 35 millimeter. All those patients and uncontrolled hypertension, patient with intermittent pain, all these patients need to be selective and then treated with TEVAR. And then we can just debate about how long that the TEVAR should be, how much coverage we should do all the way to the diaphragm, or even continue with the kind of uncovered stent down to the kind of visceral segment, something that we can debate for many years. But I think we need to come up with internationally, our society, as a kind of the group, we need to come up with some consensus agreement how we're going to diagnose them, assess them, how we're going to treat the acute, subacute, and then chronic patients. And until we had more advanced technology improvement in the branch stent grafting and fenestrate stent grafting and management of false lumen in the endovascular therapy site. And for me, it still is an open surgery in the selective center with plenty of experience. It should be the way forward to continue to treat these patients and with the open surgical repair.
This is very elaborative. Thank you very much, Prof. Wu. I'm just going to move now the question. Dr. Barry, feel free to comment on this as well. Mark, the criteria for determining patient suitability for TEVAR versus open surgery. The reason I'm asking you this is because of the consensus. Christoph, feel free to add your comments as well here. Are not explicitly declared in many studies. Okay, so the criteria are not explicitly mentioned. What's your comment on this, and what criteria we should follow? This is completely confusing now. Would you like to comment on this, Mark?
I think when you have a chronic dissection and you don't want to treat it with an endograft, then the only criterion to do open surgery is the size. And then it depends if you have to do with connective tissue disorders or not, because then the size limit is a little lower. I would say 5 centimeters. In the non-connective tissue pathology, I would say 6 before treating them open. For the TEVAR criterion, I rather switch the phone to someone
Yes,
else.
Dr. Bavaria, any
So-
lights on this?
Yeah, so this is for me,
Yeah.
since I do both TEVAR and open surgery on a routine basis, I have a strict, clear-cut, at this time in history, algorithmic approach. And that is we go for TEVAR first, conceptually. We've already established the indications for surgery, so now we've already decided we're going to go surgery. In my opinion, based on our data, if you have a good proximal landing zone, if you have a large primary tear site that you can cover, if you do not have significant coarctation of the aorta or pseudo-coarctation of the true lumen, okay, those three things. If those rules of engagement are met, then we TEVAR everybody first, no matter how old or what they are. And if you don't have those, and the last one really is the number of, if you have all 4 of the major visceral vessels coming off the true lumen, or even 3, that's a sign that there's kind of a minimal amount of distal fenestration sites, which is key. So if you have all these criteria that are positive, then I would TEVAR everybody. And if you don't, then I do open surgery in all of them. And it's very algorithmic.
Yeah, yeah, sorry, go ahead.
From an interventional point of view, I completely agree with what Joe just told us. I mean, there is a algorithmic approach with a patient with complications being the number 1 candidate for an interventional endovascular procedure to get rid of malperfusion, maybe to seal an entry tear and get rid of expanding false lumen pressure and all the other complications that we mentioned and discussed before. If that's not possible for anatomic reasons or other reasons, I think then open surgery comes into play. The other indication for open surgery, I do say in patients with connective tissue disease in the chronic situation, in a chronic setting. That's a different topic. But for the acute, subacute, and all patients with complications, TEVAR should be first choice.
Now, it's interesting. In my practice, it's about 50-50. It's about, of all the patients who come in my office, 50% will fit that rules of engagement and will get a TEVAR. But 50% will not, and will end up having to do an open operation.
Professor Carrel, did you want to make any comments on this
It
further?
was just regarding the patients with connective tissue disease, because my own experience is sometimes they have not a very enlarged descending aorta when they dissect. Might be below 3.5 centimeters. And of course, we are sometimes reluctant to put endovascular graft in very young patients. So, but of course, just to overcome the acute phase, it might be very interesting. Yeah.
So I know that you all have other commitments to attend to. Just that, for the audience, it's a take-home message. Prof. U, would you like to say what's the take-home message that the audience needs to, build on and capitalize and understand very carefully from what we heard from the panel?
Take-home message is to manage the chronic dissection where you need to start from acute dissection. It's acute type B dissection. Diagnose, and then all the patients should have a kind of good blood pressure management, assessment of malperfusion, CT on the day 1, day 3, day 7, keep them within hospital for about 10 days to 2 weeks, and then making sure they reassess in outpatient clinic, and then we can then decide whether patients should have a elective TEVAR for uncomplicated type B, to modify the kind of natural history. And then there will be some selected patients that will be suitable for TEVAR routinely, and there will be some selected patients with the chronic, the connective tissue disorders, strong family history of kind of ruptures, and then they may be that require, and then require the kind of treatment with the surgery in some patients.
Great. Any comments further on this, Christoph?
I would just mention 3 summarizing points. Number 1, preemptive TEVAR is a reality. Number 2, you have to identify the high-risk features in a given patient. And number 3, I think long-term follow-up for every patient is key as well, to identify late complication that you want to tackle later on.
Yeah, I think there's a couple of really important points that the audience should know. The first one is that really the biggest area that's making TEVAR a little bit hesitant is that in the acute phase, and even in the chronic phase, but it's certainly in the acute phase, the studies have been done at the US FDA. They're clear. There's a 6%, 5 to 6% retrograde type A dissection rate placing TEVAR in acute type B dissection. So that is the only thing that is kind of holding us back from putting TEVAR in almost everybody with an acute type B dissection, is that. And so we're not going to be able to put in TEVAR in uncomplicated type B dissections until that number comes down a little bit. And we have to work on that as a group. And that's the key point.
Thanks,
Just
Professor
a general
Levere.
comment. I think every patient with acute type B should be referred to a special center with all possibilities. And this is in many countries not the case. They are
Well
just
said, yeah.
monitored on intensive care station by intermedical doctors. And I think it's very important as the vascular specialist, either the endovascular or the surgeon, has to put his diagnosis and the algorithm of which treatment is needed by which patient.
Smashing. Dr. Chaffin?
I would like to say that open surgery for chronic type Bs is not dead. Certainly not. One example are the connective tissue disorders. Another one is patients who were treated before with TEVAR with endoleaks or with distal complicated complex dissection flaps which are not treatable by endovascular way.
Thank you. And the last comment to you, Malak.
I've got only 2 points to make. One is that just like the heart team in TAVIs, I think also for these there has to be a team-based approach. If someone is like Joe doing both, then it's okay. But if you don't have that, then at least the surgeon and the interventional, either a radiologist or a cardiologist or someone doing the interventional part, they switch it together and discuss, I think, one. And second, sadly, at least in German system, what we see is that because of the massive explosion of the TEVARs now, the open repair surgeons are going down. And I believe that maybe, unfortunately, in 10 years, I don't think there will be many people who can do the open repair. That is one unfortunate part, at least what we see right now.
Well, thank you very much for all your time and your thoughts today on this controversial topic. Please enjoy Birmingham as much as possible. For CTSNet, this is Mohammed Bashir. Thank you for joining us.